First of all, I'd like to thank John and the organizers for inviting me here today to share some of our findings with you. It's always a daunting task coming after Bob, who always does a fantastic lecture, especially with his special patient story at the end. So these are my disclosures. We receive funding from various funding bodies, and I'm also lucky that we've recently founded a company that has an aim of bringing some of our basic observations into clinical practice. So you've heard very eloquently today from Bob that chronic inflammation is really important in many of the inflammatory diseases that afflict modern societies. And one of the reasons why we've become interested in chronic inflammation is because it leads to a significant decrease in quality of life, and it has a significant socioeconomic impact on patient populations. And we've heard about the understanding of the inflammatory response being divided into two phases, the initiation phase and the resolution phase. And fundamentally, as Dr. Martindale nicely illustrated earlier, fundamentally, inflammation is a protective mechanism. It's evolutionarily been developed to help the body fend off bacteria and repair and regenerate damaged tissues. And for many years, people were interested in understanding what's going on in this inflammatory response, because it was thought that it was, in particular, during the initiation phase, an excess production of molecules like cytokines, chemokines, and classic eicosanoids that led to chronic inflammation. And the identification of these molecules led to development of anti-inflammatories, which we now have hundreds of in our pharmacopoeia that include the widely used non-steroidals, as well as the recently developed biologicals. And the aim of these molecules, these drugs, is to inhibit inflammation. It's to inhibit this initiation phase of the inflammatory response, to block the production and the activity of these molecules. And obviously, we appreciate they've been successful in doing that, and they have clinical utility. This approach has a clinical utility. However, it does also come with several unwanted side effects. So first of all, they're only effective in about 50% of patients. They don't promote tissue repair and regeneration. There's this idea of resolution toxicity, and I'll come to it a little bit later on. And some of them also present with major systemic toxicity. So this really spurred the need to identify new ways to regulate inflammation. And you can easily appreciate that we've only really looked at half of the inflammatory reaction. And as Dr. Martindale mentioned, for many years, the resolution of inflammation was thought to be a very passive process. So these inflammatory molecules were thought to get eventually diluted out, and that led to then the removal or the egress of white blood cells from the site of inflammation, and then inflammation went away. However, the Serhan group and the group where I trained became interested in really querying whether this hypothesis was true. Does inflammation resolve passively, or are there molecules that are produced at the site that regulate white blood cell behavior to stop inflammation and promote repair and regeneration? And to do so is a systems approach. So inflammatory exudates were collected from animal models, and they were collected at different stages of the inflammatory response during the initiation and then during the resolution. And these were then characterized for their cellular composition and cellular functions. And the reason this was done is to be able to map exactly which stage of the inflammatory response we're at. Are we during the initiation? Are we during the resolution? After that, a lipidomics approach was used to measure the known molecules, the classic eicosanoids, prostaglandins, leukotrienes, thromboxane, as well as to conduct a structural elucidation approach to identify new molecules, new candidate molecules that could be important in terminating the resolution of inflammation. And using this approach, and as Dr. Martindale mentioned earlier, we found that eicosapentaenoic acid was precursor to a new family of molecules termed as E-series resolvins. And importantly, these molecules are produced via very specific reactions that are catalyzed by enzymes. So these molecules don't spontaneously appear, but are produced actively by white blood cells that carry specific enzymes to convert the fatty acids into specific structures. Docosahexaenoic acid was also converted to 3 new families, termed as resolvins, protectants, and merisins. And each of these mediators carries common biological actions. They all limit leukocyte activation, they limit leukocyte trafficking, and also downregulate the production of inflammatory mediators. And I chose that word downregulation specifically because none of these mediators inhibit the production of inflammatory mediators. And this is a key difference between pro-resolving mediators and anti-inflammatory drugs. As we know from years of clinical evidence, inhibition of inflammatory pathways can lead to severe side effects. For example, anti-TNF therapeutics expose the body to infections, right? Non-steroidals leads to GI bleeds, whereas these mediators don't completely block these inflammatory pathways. What they do is they reduce the production so that you don't have active inflammation anymore. But these pathways remain active, so if there is another insult, the body can actually deal with it. We also know that the biological actions of each of these mediators goes through specific G protein coupled receptors that are regulated in a cell type specific manner. And one of the key aspects of the regulation is through NF-kappa B, and we also know that they regulate microRNAs, and I'll come to it in a few slides. And we've now, and as Dr. Martindale mentioned, we now know that these biological actions are spread, at least in experimental models of inflammation, going from inflammatory bowel disease to infections. We have sepsis, as well as viral infections, asthma, tissue regeneration, stroke, arteriosclerosis, pain, and the list keeps growing. And one aspect that we've recently become interested in understanding is this role of microRNA and how microRNAs signal through the pro-resolving mediators. And indeed, what we found was that there's a cassette of microRNAs that in acute inflammatory exudates is regulated both in animal systems as well as in human cells. And they play a role in mediating the biological actions of pro-resolving mediators, where the activation of, for example, GPR32, which was one of the resolvin receptors, leads to the downregulation of miR-146B, miR-208, and the upregulation of miR-219. And this has an impact on the levels of these molecules that are downstream of these microRNA. We also now know that these mediators are produced in healthy people in the absence of inflammation. So they go beyond just promoting resolution to maintaining homeostasis. So this is how our body keeps the normal function through the formation of these mediators, or at least this is our working hypothesis, whereby the production of these molecules in different organ systems throughout the body, where we find these mediators at biologically relevant levels. For example, in milk, there are several studies that now show that there's also a temporal regulation from time after birth, so from the colostrum all the way through up to 1 year after birth of the infant. And the levels of specific mediators change. In spleen, we know that there are these mediators as well as in lymph nodes, which suggests that there is also a role in the training of the adaptive immune system. And more recently, we found that N3-docosapentaenoic acid, which was thought to be simply an intermediate in the formation of docosahexaenoic acid from icosapentaenoic acid, is also important in the formation of several new families of mediators. And each one of these mediator families is important in regulating leukocyte responses. For example, they regulate the activation of the NLRP3 inflammasome, which is important in production of IL-1 beta. They counter-regulate the production of pro-inflammatory eicosanoids and increase phagocytosis of bacteria and killing of bacteria, as well as regulate endothelial cell responses, so regulation of adhesion molecule, for example, and prostacyclin. And we now know that these pathways also interact with widely used therapeutics, and they mediate the protective actions of statins, for example, atorvastatin, simvastatin, and lovastatin, as well as aspirin. And they do so via, whereby these pathways engage the biosynthetic pathways, the production of these molecules, and upregulate each one of these different mediator families. And in experimental systems, if we block the formation of these pro-resolving mediators, we lose the protective actions of these therapeutics. So for the next few minutes, what I'd like to review with you is some recent concepts that we've been working on, and is that we now see that there is a diurnal regulation of these pro-resolving mediators in healthy people, and that the loss of this diurnal response correlates with cardiovascular disease. We've become interested in understanding how these molecules are controlled, and we now see that there's a neuronal control of these pro-resolving mediators at a tissue level, and this has an impact on the ability of the host to clear infections. The utility of nano-pro-resolving medicines that are produced from microvesicles as potential therapeutic tools for delivery of these mediators, especially in tissue regeneration. And then the use of a platform that we've developed for functional lipid mediator profiling in order to understand whether a patient is responding to a specific treatment or not. So, as you all appreciate, and this concept has become, I think, as far as I think at least, widely accepted, that a lot of our basic functions are regulated in a diurnal manner. So morning to night, there are different changes in our physiological functions. And one of the functions that we've been interested in is how blood cells are regulated in a diurnal manner. How do these cells behave in healthy people, and what happens when you get cardiovascular disease? So in order to address this, we set up a platform where we can measure these pro-resolving mediator families, the 4 mediator families. We can measure their precursors, the bioactive mediators, and then some of the further metabolites in peripheral blood from healthy people, and we can measure all these molecules simultaneously. And what we found was that there was a temporal shift in the production of pro-resolving mediators in healthy people during the day. So from 7 o'clock in the morning all the way through to the late afternoon, we can see a change in the production of pro-resolving mediators. And in particular, there was a selective regulation of these N3-docosapentaenoic acid-derived resolvins, whereas you can see there's an increase during the early morning hours, and then they go back down later on in the day. And this was correlated with an activation of monocytes as well as platelets in the blood. So at the same time that we see an increase in these pro-resolving mediators, we see an increase in monocytes and platelets. And this change in white blood and peripheral blood cell activation has been reported for many years, and it has to do with the increased blood pressure that occurs very early in the morning before we wake up. So we questioned, does this increase in pro-resolving mediators help to maintain, as a brake, to maintain this activation within sort of acceptable limits? And so in order to address this, we obtained blood from patients with cardiovascular disease and assessed whether the production of these pro-resolving mediators was differentially regulated. Indeed, what we found was, where in healthy volunteers there was an increase in the early morning hours, this was lost in patients with cardiovascular disease. So in addition to reducing the overall levels, there was also a lack of this diurnal response. And this was associated with a significant upregulation in peripheral blood cell activation. And these, in particular, platelet monocyte aggregates, are also associated with an increased risk of myocardial infarct and stroke, because they form microthrombi that then can block the blood vessels. And what we can see also in these patients is that there is a significant negative correlation between monocyte activation and the peripheral blood levels of these pro-resolving mediators, as well as these platelet monocyte aggregates. And importantly, when we get blood from these patients and we incubate it with either resolvin D2 or resolvin D5 from the N3-DPA metabolome, we see a significant and dose-dependent reduction in peripheral blood cell activation. So this supports the hypothesis that indeed these molecules are important in acting as a brake, and by losing the production of these mediators, we lose we increase platelet activation and monocyte activation, and we see it both as aggregates as well as when we look at the expression of an adhesion molecule that is associated with cellular activation. So the other aspect that we're now interested in is how the body regulates the formation of these molecules, both under homeostasis and then once inflammation starts. And the central nervous system, in particular the vagal nerve, the efferent vagal nerve, have been implicated in the regulation of host responses in many peripheral organs. So we question whether this was also true for the pro-resolving mediators. And indeed, what we found was that in animal systems, the vagus nerve innervates the greater omentum, and in the greater omentum, there is a neuronal leukocyte plexus where via the production of acetylcholine, this neurotransmitter signals to a group of cells known as group 3 innate lymphoid cells. It upregulates the activity of one of the pro-resolving mediator enzymes to produce this new family of mediators termed as protecting conjugates in tissue regeneration. And these mediators are important in regulating peripheral macrophage responses. So they make the macrophage respond better to an inflammatory stimulus, in particular to infection. And if we disrupt the vagus nerve in mice, if we cut this vagus nerve, we lose this axis. And indeed, the peritoneal macrophages cannot uptake and cannot clear bacteria as well. And we get a delayed in inflammation, in the resolution of inflammation, and also an increase in bacterial titers at the peritoneum. And this is because it impinges also on this temporal shift in pro-resolving mediator production in the tissue. So different mediators are produced at different times, and they act to regulate different cell subsets. So let's see, we take an example, this infectious inflammation, where bacteria are injected into the peritoneum. They're sensed by the resident peritoneal macrophages that produce merisine 1. As the inflammation progresses, resolvin D5 becomes important, and this helps clear the bacteria together with protectin D1. And then there is a shift in the macrophage phenotype. We get a resolution phase macrophage phenotype that help clear the apoptotic cells from the site of inflammation and upregulate the formation of these merisine conjugates in tissue regeneration that are important in setting the stage for repair and regeneration of the damaged tissues. So the minute we disrupt early on the signaling, we lose this temporal shift, and so we lose the ability to repair and regenerate tissues at the site. We've also been interested in addressing whether we can use measurements of these pro-resolving mediators in order to understand whether a patient is responding or not to a specific therapeutic. And in this particular case, we're looking at a combination of aspirin as well as essential fatty acid supplementation. So what we're giving here is, these are healthy volunteers. We obtain blood before supplementation, so before giving essential fatty acids, which are primarily EPA. After 2 hours, we get aspirin, and then 4 hours later, we get blood again. And we measure the levels of the pro-resolving mediators in blood before and after supplementation. And in order to get an insight on function, on white blood cell function, we measured the ability of peripheral blood cells to uptake bacteria, because we know that these mediators, one of their main functions is to regulate bacterial phagocytosis. And what we find is that there is a significant shift in the levels of mediator before and after supplementation. So each one of these dots is a volunteer, and the green dots are before, and you can see that the green dots are in a different space to the blue dots, which is after supplementation. And in particular, this is because there is an upregulation in the levels of a group of pro-resolving mediators from the DHA metabolomes, so resolvin D5, resolvin D1, and resolvin D2, as well as an aspirin-triggered protectin D1. And we also see an increase in the EPA-derived mediators too, so resolvin E2 and resolvin E3. In terms of function, we see a significant upregulation in the ability of peripheral white blood cells to eat bacteria. And if we plot the increase in that group of mediators against the ability of white blood cells to phagocyte those bacteria, we see that there's a significant positive correlation. So the more of these molecules you get, the better you can eat the bacteria. So this suggests that measuring these mediators in peripheral blood can give us an insight on how the body is going to deal with an inflammatory stimulus, in this case, a bacterial infection. Another aspect that we've been interested in is the role of these microparticles or microvesicles in regulating leukocyte responses. So microvesicles are small membrane-bound vesicles that are produced by virtually every cell in the body, and they've been linked with both stopping inflammation as well as increasing inflammation, and the mechanism for this is that the cell will produce a vesicle that has different properties dependent on how it is activated. So we were interested in understanding whether during this self-limited inflammation, neutrophils produce microvesicles that help promote the termination of inflammation. And indeed, when we measured the levels of microvesicles in an inflammatory exudate, we find that neutrophil microvesicles persist through the resolution phase of inflammation, suggesting that they might be playing a role in particular in reprogramming monocytes and macrophages during the termination of inflammation. And indeed, what we find is that if we put these microvesicles with human macrophages, we see a dose-dependent increase in the ability of the macrophage to eat to eat apoptotic cells. And this is an important step in termination of inflammation because it's the cleanup step. The macrophages are important in cleaning up the site so that we can go to repair. And they do so, at least in part, by feeding the macrophage here, by feeding the macrophage precursors to produce more pro-resolving mediators. And they upregulate the formation of several families of these pro-resolving mediators, and thereby regulate macrophage function. So then we questioned, can we use these microvesicles as scaffolds to enrich them in pro-resolving mediators so they can be better at doing this job? And that's what we did. We enriched them in one of the pro-resolving mediators, in this case aspirin-triggered resolvin D1. And when we give them to mice before a sterile inflammatory response, we see a significant reduction in the number of neutrophils that are recruited to the site of inflammation, as well as in the length of the inflammatory response, where in mice that were just given the inflammatory stimulus by itself, the neutrophils leave the site in about 7 hours, whereas in mice that were given these nanopro-resolving medicines, this is reduced to 4.5 hours, nearly halving the amount of time that it takes for the inflammation to go away. So seeing this in a mouse model, we wanted to go sort of get a little bit closer to humans. So the next thing that we did, and this is through collaborations with a group at the Forsyth Institute, Tom van Dijk's group, we've had a long-standing interest in periodontal disease because periodontal disease is linked with many of the other inflammatory diseases that we're interested in, cardiovascular disease, as well as other peripheral organ diseases. So here we used a mini pig model. Don't let the name fool you. It's not as mini as you would like to think, or at least as I thought. So the mini pigs have a head that's more or less the size of a human. And so we've set up this mini pig model of periodontal disease where you can get similar inflammatory pockets. So these red areas, this is where the bone is being lost. You can see that there's a recession in the gum line and a significant bone loss. If we implant these nanopro-resolving medicines into these pockets, into these gingival pockets, and we look 2 weeks later. So we gave 4 different treatments, saline by itself, the microvesicles by themselves. In this case, we use a lipoxin analog, and then these enriched nanopro-resolving mediators. And if we look 2 weeks later after implantation, these are micro-CT images, and in red is the new bone growth. So in those animals that received only the vehicle, there was no new bone growth. You start seeing a little bit with the 2 components separate, but once you combine the 2 components, you have a significant bone growth that is also quantified here. And these are the images. So these are the gums of an animal that was given only vehicle, and these are the gums of an animal that was given these nanoproresolving medicines. And as you can see, it more or less goes back to what it was before the start of the model, suggesting that indeed if we use this approach, we can actually improve the biological actions of these proresolving mediators as a delivery system. So we now think that we're slowly moving away from what Hippocrates in his time had started, in the sense that he, back in the 4th century before Christ, he used to use the bark of willow tree to inhibit inflammation. We now know that this is rich in salicylates, so this was the precursor, if you will, to aspirin. But by using this pro-resolving approach, by promoting the termination of inflammation rather than inhibiting inflammation, which is what we've been really drilled in to do for the last few decades, we can improve the termination of inflammation, we can improve tissue repair and regeneration, because this time what we're doing is we're counter-regulating the production of mediators, we're reprogramming both the innate and the adaptive immune response. I didn't have time to go over this, but there's now extensive literature showing that these mediators also regulate T-cell responses, they regulate B-cell responses, they lead to a reduction, for example, in allergies, reduction in IgM from B-cells, and also promote tissue repair and regeneration. So this allows us then to harness the body's own ability to repair and regenerate itself and to terminate inflammation. And we hope that this will then result in a lower burden of side effects. And as far as we can see, at least in the animal systems and the early clinical trials, this seems to be holding true. So in summary, I hope I have convinced you that the resolution of inflammation resolution of inflammation, SPMs play a key role in the reestablishment of homeostasis during both infectious disease as well as sterile inflammation. The N3-DPA-derived resolvins are really important in the diurnal regulation of peripheral blood cell responses, and they by reducing platelet and leukocyte activation, and losses in the production of these molecules are what may lead to cardiovascular disease. We now know that neuronal circuits are important in regulating tissue pro-resolving mediator production and in maintaining what we call tissue resolution tone, which is the ability of the host, that particular tissue, to regulate inflammation when challenged, and the utility of peripheral blood mediator levels as a novel tool for biomarker discovery and using for patient stratification and treatment efficacy. So I obviously would like to thank members of my group for their work, our collaborators and the funding bodies. And I'd like to leave you with these two messages. So we think that resolution-based therapeutics provide new opportunities for the control of unwanted inflammation and tissue regeneration via reprogramming the host immune response. And profiling of the resolution metabolome may provide new biomarkers for measuring treatment effectiveness and patient stratification. With that, I'd like to thank you.